the Princess Margaret Hospital, and she will be presenting to us on Treat or Dig Deep, a case of inflammatory breast cancer. Now, as you know, this is October, and October is Breast Cancer Awareness Month. So we're going to take the time to educate ourselves a little bit more on breast cancer and a form that we may not typically see or hear of. So for those of you who do not have the pleasure of knowing our presenter, I will introduce her to you. Dr. Talietha Diane Minnis is a proud graduate of the University of the West Indies, St. Augustine's, and Bahamas campus, and completed her internship at the Princess Margaret Hospital. After completing medical school, she worked as a senior house officer in the Department of Radiology for 2 years, where she fell in love with the field. She decided to continue her studies to specialize in diagnostic radiology at the University of Witwatersrand in Johannesburg, South Africa. She returned home as a trained radiologist in 2019 and became the director of radiology at the Princess Margaret Hospital in 2021. Dr. Minnis has a passion for her patients and shows particular care in integrating her love for Christ and her daily interactions with them in the public and private sector. She endeavors daily to ensure that her walk in her professional life lines up with her walk with Christ. So please welcome with me Dr. Talietha Minnis, presenting to us today on Dig Deep or Treat, a case of inflammatory breast cancer. Dr. Minnis?
Good morning. Just testing. Can you hear me?
Yes, we can.
Righty. Just share my screen. Okay, seeing my screen?
Yes, we are.
All right. As Dr. Wallace Bain has said, I am Dr. Talietha Minnis, and I'm the Director of Radiology. And my case presentation this morning is about Treat or Dig Deep. I chose this topic because in our clinical setting, a lot of times we see these patients and inflammatory breast cancer is usually misdiagnosed, or the diagnosis is arrived at much later than most non-inflammatory breast cancer cases. And so we recently had a case that I thought was interesting to present. Bear with me as I present, a little nervous, but hopefully you will find benefit to what I'm presenting this morning. I do not have any disclosures at the moment. So I'll start with my case. My case is a 46-year-old Black female. She was Bahamian. She was hypertensive, controlled with medication. She had no prior breast issues, meaning she's never had a lump. She's never had an abnormal mammogram done. She's never had any breast discharge. Her previous surgical history was just a D&C at age 28. She has 3 children, age 15 to 21. She's a non-smoker, and she has occasional alcohol use. She has no family history of breast cancer. Her presenting complaint. She presented with a focal area of pain and redness to the left breast 1 month prior to presenting to PMH. At that time, she did not have a palpable lump. She had no punctum on the skin. She had no associated nipple changes or discharge, and she had no other skin changes, so no ulceration or dimpling, and she had no fever at the time. She also had no history of recent trauma to the breast. She presented to her GP, who suspected a possible infection and/or mastitis. She was placed on antibiotics for 1 week with a follow-up appointment. On that follow-up appointment, there was no resolution of pain. She had increased redness, and now there was a palpable mass. She was then sent for a mammogram at a private institution. When she arrived at that private institution, she opted not to do the mammogram because she was in so much pain and decided to just do the ultrasound. The report at that time described a large irregular mass that was in the left breast at the 9 o'clock position. There was significant subcutaneous edema in all the quadrants. She had enlarged axillary nodes with no fatty hilum in the left axilla, and the right breast was normal. I've placed a picture of what that ultrasound looked like, that mass, in the lower aspect of the screen. And just to point out some features that I'm seeing on the ultrasound that were suspicious at the time, which was a month prior, the mass is hypoechoic, which means it's darker. It's taller than it is wider. Benign masses tend to grow more horizontally in plane with the breast parenchyma, but suspicious masses or more aggressive masses tend to burst through those planes and grow taller in a vertical position than in a horizontal plane. And also, there is a feeding vessel directly in the middle of this mass that already puts my antenna up for it being highly suspicious. The impression on that report was that although the mass is highly suspicious, the inflammation is so severe that the picture may mimic a malignancy. And it was thought that the lymph nodes were overwhelmed rather than invaded. The recommendation on this report said that aggressive treatment of mastitis should be done with review before a biopsy is done. She was treated for 2 more weeks, and then finally, with no resolution, she was sent and referred to the PMH surgical clinic, where she was then referred to the radiology department for an image-guided biopsy. Once she presented to PMH, this would have been only 4 to 5 weeks from the time of her initial onset of symptoms. As you can see in the picture, in the left breast, there's significant diffuse erythema throughout the entire breast or redness. There's puce orange or orange peel skin that tends to happen with inflammation. It was twice the size of the right breast. It was firm, it was warm, and it was painful. We did another scout ultrasound at a time before we did the biopsy. And if you can see, the mass now, 4 weeks later, looks significantly more aggressive. There's now posterior acoustic shadowing. There is still uptake of the vessel centrally in the lesion. And there's now significant surrounding peripheral color uptake in the surrounding inflamed tissue. Just for comparison, on the left breast, the red line demonstrates the thickness of the skin in all of the quadrants. On the left, which was 6 millimeters, and on the right, in the normal breast, it was only about 2 millimeters. So significantly diffused skin. So the biopsy was done and 5 successful samples were taken. Unfortunately, at the time, no skin punch biopsy was done. It took about 3 weeks for those results to come in, and it came back as invasive ductal carcinoma with micropapillary features. Lymphatic involvement was not noted on the samples that were sent. This was not in the report. However, I did call back to find out if any lymphatic invasion at the time was seen, noting again that I did not do a punch biopsy at the time that we saw the patient, and urgent immunohistochemistry was recommended. We then called her back in to have her staging CT scan done. And this is an axial cut through the chest that demonstrates that the left breast has significantly thickened skin in comparison to the right. There was an irregular, hyperdense, enhancing mass that was noted medially in the left breast. And there was also some areas of architectural distortion and enhancement noted laterally in the breast as well. That was concerning for us. She had level 1 axillary nodes, just noting that they are lateral to the pec major and minor. She also had some level 2 axillary nodes on the same side, on the ipsilateral side, just deep to the pec major and minor. And she also had some level 3 axillary nodes. She had ipsilateral supraclavicular nodes at that time, and she had no distant lung, liver, or bone mets. So that brings me to my topic of inflammatory breast cancer. And what is it? Inflammatory breast cancer is a rare aggressive subset of breast cancer that's usually diagnosed from the clinical presentation. It accounts for 2 to 5% of all breast cancers, and there's a 5-year survival rate of 41%. There are 2 types, usually primary IBC, which is usually IBC developing in previously normal breast, which is the most common one, and secondary IBC, that are IBC features that happen on reoccurrence in a patient that may have either had inflammatory or had a non-inflammatory cancer and now is presenting with inflammatory features on recurrence. A palpable mass or lump is present only in 1/3 of these IBC patients at diagnosis. And in the IBC network, they tend to say no lump, still consider cancer. How is IBC different from other locally advanced breast cancer? The clinical signs tend to be distinctive. Classically, they have warm, rapidly enlarging, swelling breasts due to the blockage of lymph vessels and tumor emboli. And emphasis needs to be focused on rapidly enlarging because this is where clinicians tend to miss thinking about cancer. They think the time frame is too short. It must be some acute infective process as opposed to some long-term process. The time frame is usually less than 6 months. The redness that's occurring usually covers more than a third of the affected breast. There's peau d'orange, as we saw in our patient, of the overlying skin, breast pain, and nipple changes. So that could be nipple retraction, whether there's flattening of the nipple or if there's just crusting. My patient just had some crusting of that nipple. What are some of the imaging differences that occurs with these masses? Again, there's usually no palpable mass in about 2/3 of these patients. So mammograms tend to miss about 50% of these IBC cases. It's usually more difficult to diagnose on routine imaging. This is just a comparison of a mammogram for an IBC patient on the left side of your screen. It just demonstrates skin thickening in that right breast. There's coarseness of the stroma, which is like the white strings, I would say, inside the breast parenchyma. The black is usually fat. So these fibroglandular tissue tend to look more coarse on the mammogram. And there's usually just some increased breast density. And in non-inflammatory breast cancer cases, as you can see, there's usually a discrete lump on the right side of your screen and there's usually some microcalcifications. I don't know if you can appreciate that. There is skin thickening that's associated with it, sometimes a nipple retraction. However, you can see how much easier it is to pick up a mass in a non-inflammatory breast cancer case on a mammogram than it is on an inflammatory breast cancer case. It tends to be quite vague on the mammogram. The demographics of IBC patients versus non-IBC patients, they tend to be a younger median age of diagnosis. I tried to find some statistics specifically on inflammatory breast cancer, but that's not documented that way. Here in the Bahamas, I couldn't find specific information, but we know that we have a younger age of presentation of non-inflammatory breast cancer patients. And so those inflammatory breast cancer patients are going to present younger than that median age. Black and Asian women tend to be diagnosed younger than our white counterparts. And 15 to 20% of inflammatory breast cancer occurs in patients with a family history of breast cancer. So that leaves 80 to 85% of patients who would have not had a family history of breast cancer to present with inflammatory breast cancer. And our patient did not have a family history of breast cancer. And usually, if they say they have the family history of breast cancer, it kind of cues you in to think about it. She did not have that history. So, what are some of the reasons that inflammatory breast cancer can be misdiagnosed? Most times, clinicians tend to go with the more benign diagnosis, such as infection, a mastitis, or breast abscess, and they tend to start a trial of treatment. And there's nothing wrong with starting that trial of treatment. The issue is when the patients don't either follow up or the clinician does not have that high index of suspicion that, hey, this thing is not resolving. The treatment that I'm giving to them is not helping. We need to move on to further investigation. We need to dig deeper because something is still wrong. Sometimes in patients who would have had previous cancer and had radiation, post-radiation changes can be misdiagnosed for a recurrent inflammatory process. And also patients that may have had some kind of trauma or insect bite that is just a red herring to the fact that they've now presented with this redness on the breast. So they'll present to the clinician, say, yes, I got a mosquito bite or something bite me there, and or I was in a car accident and I got hit with this, with the seatbelt or something happened and now I have this redness. And they can just be red herrings, and then the clinicians tend to treat that symptom and don't do a quick follow up on these patients to ensure that we dig deeper for something else that's underlying. So, the clinical diagnosis, along with the clinical symptoms that I've described that are usually pathognomonic for this process, the workup usually includes, as I said, a mammogram. Um, I always still advise that you start with a diagnostic mammogram, even though 50% of these patients will not have a mass that will show up on it. The reason is that you may pick up on another cancer on the other side and or other findings within that breast that's not related to the inflammatory breast cancer. However, these patients tend to be painful, and if they cannot tolerate the mammogram, I suggest you not force them and move on to the next imaging modality. You should always move on to the ultrasound after you would have done a breast a mammogram, because the purpose of that is to look specifically for an underlying mass that you can target via biopsy. A lot of times you won't see anything on the mammogram, so doing that ultrasound is important, whether you're looking for the mass, looking for an abscess, or some other cause of this inflammation. If the ultrasound is negative and the only thing that you're seeing is the inflammation in multiple quadrants, then you should move on to doing an MRI for these patients so that you can possibly find a lesion that you can target via MRI. The metastatic workup should be PET CT, that's highly recommended. However, if it's not possible, a CT of the chest, abdomen, and pelvis is fine using IV and oral contrast, and then a bone scan should also be done. Some of the pathology concepts of inflammatory breast cancer. It must be confirmed by core biopsy. So I don't know that people still would do a FNA for these things, or maybe just the nodes. You should try to get a core biopsy sample, whether that's by ultrasound, whether that's by MRI guided, so that you can send the sample on for receptor studies. It's recommended to do 2 skin punch biopsies to determine the presence of lymphovascular emboli. As I stated, I did not get to do that punch biopsy on this particular patient, but it is recommended that you do it in the most red area, and you should try to get at least 6 to 8 millimeter thickness of a sample. The dermal lymphovascular emboli. This is frequently seen in inflammatory breast cancer in 50 to 75% of cases. They usually are larger than in the locally advanced breast cancer. However, it is not required for the diagnosis. because as you can see, 25% of these patients will not actually have this lymphovascular emboli. And so if you only see this dermal lymphovascular emboli without the clinical presentation, is not sufficient to make the diagnosis. You should go on to do the hormone receptors, and this is just a slide for the pathologist. I'm not going to go deep into that, but estrogen receptor staining equals brown in the nuclei, and then the HER2 staining is brown on the surface of the cell. IBC is not a histological subtype of cancer, and the pathology report may not state inflammatory breast cancer itself. Be possible to differentiate the IBC from other invasive breast cancers. The most common histologic subtype is invasive ductal cancer, carcinoma, and that's what our patient had. So, invasive breast cancer plus the clinical criteria, you should think inflammatory breast cancer. The staging for inflammatory breast cancer, as per the AJCC guidelines, is still the TNM. But of note, once you are considering inflammatory breast cancer, the T stage is already a 4, regardless the degree of edema or if there's an underlying mass at a particular size. By definition, these tumors at T4 are already a stage 3. And I want to make sure we understand and hear that these patients that are presenting to you with these inflammatory or infective-like picture, if it is inflammatory breast cancer, they are already sitting in the front of you with a stage 3. So it is important to have a high index of suspicion so that you can refer them on quickly. Just a quick slide on the distribution of IBC staging at diagnosis. The stage of IBC at diagnosis, 30% of these patients are going to present to you at stage 4. And the majority of patients in non-IBC patients, as you can see, is going to present to you at stage 1 and 2. Again, so it is imperative to have it as a high index of suspicion when you see these patients in clinic, or even personally, if you are experiencing these types of symptoms, don't sit on it. Don't think it's just infection. Try to dig deeper and understand what else is going on. So the final diagnosis for our patient was indeed invasive ductal carcinoma. She was already T4 because she was inflammatory. She had level 1, 2, and 3 axillary nodes, so she was N3, and indeed at stage 3C. The treatment for these patients, and I'm not an oncologist or a surgeon, so it's definitely an aggressive treatment. Usually they get systemic therapy with chemotherapy and targeted therapy if there are positive receptors. After there's partial or some maximal response, they will go on to some type of local regional therapy, whether it's a modified radical mastectomy or axillary dissection. And then after that, they tend to go on to continue with adjuvant treatments for hormone receptors. So in my case, she had all the clinical criteria to suspect an inflammatory breast cancer process. She had a suspicious mass on imaging, and she was still treated for mastitis for about 4 weeks before she presented for a biopsy. She's currently still going through her journey. In conclusion, inflammatory breast cancer is an aggressive form of cancer and presents rapidly. Although rare, clinicians should have a high index of suspicion for the diagnosis. A trial of antibiotics is not a poor choice for a patient with this presentation. However, quick follow-up and progression to further investigation should be done if there's no response or resolution to the initial trial of antibiotics. Patient advocacy and education is important. Try to impress upon your patients that yes, we may be thinking an infection initially, but please do not stay away. Ensure that they come back. Follow up with these patients to ensure that is the treatment working, and should we dig deeper to look for another cause of this inflammation. Remember that quick referral can save precious time to confirming the diagnosis, being staged, and starting treatment. Just a few quotes from patients that actually had inflammatory breast cancer. I went from thinking I had a bug bite on my breast to being told I had cancer. without a lump, and fast moving. My whole world turned upside down in a matter of days. Anonymous survivor. I had never heard of inflammatory breast cancer until I was diagnosed. I didn't have the usual symptoms you expect with breast cancer. No lump, just a swollen, red breast that looked like an infection. Cheryl was diagnosed at 46. My skin was hot, red, and thick. I thought it was just an infection. It took several doctor visits before anyone suspected I had cancer. Deborah. I was misdiagnosed with an infection at first, but I knew something wasn't right and kept pushing for answers. Anonymous survivor. Thank you. These are my references. And I just want to put a plug in that our machine is up. And yay, I'm happy about that. We are taking some appointments and walk-in patients at this time. Thank you. And I hand it back over to Dr. Wallace-Main for questions.
Thank you so much, Dr. Minnis. That was indeed a very informative presentation, a very, very interesting case. I know I was very tuned in very keenly because, as you correctly stated, it's really something that you need to have a very high index of suspicion for in order to get these patients quickly diagnosed and treated. And I recall having a case with a female coming in, presenting with those features. And thankfully, my suspicion was very high, and she got her referral immediately. And she did well with her treatment. So at this time, the floor is now open to take questions. Just going to move over to the chat to see if there are any comments or questions. I don't have any comments or questions. I had seen a raised hand at the end. You can, okay. Dr. Griffith-Bowe, you can unmute.
Good morning, everyone, and thank you, Dr. Minnis. I thoroughly enjoyed your presentation. No need to be nervous. It was excellent. My question is this course of this IBC, is it more aggressive in patients, in pregnant patients? Because I do recall about 3 years ago, we encountered a patient who presented similarly and was diagnosed with IBC. As far as I can recall, she is a survivor. But are there any nuances, I would say, in making the diagnosis in a pregnant female with pregnant breasts? Did you hear me?
Okay, can you hear me now?
Yes.
I will answer the best that I can. Thank you for your question. I know that diagnosing breast cancer in pregnant patients, you have to have a high index of suspicion again, because again, they are having so many inflammatory factors happening already. I don't know, and someone can help me out if they do know, maybe the oncologist, if there's specifically a higher incidence in pregnant patients. But I would be concerned, again, if that clinical criteria is there, don't just take it for breastfeeding mastitis. If you see that it is not resolving after having done everything that you should do or would do for that type of mastitis, I would suspect that you dig a little bit deeper, do the investigations that you need to do so that you can get maybe a targeted mass, so that you can get the information you need. I don't know that I answered it well, but maybe any oncologist or someone on the call could maybe jump in and speak to more if there's specific risk factors for pregnant patients.
Thank you. I think that's a question that we will we will have to maybe dig a little bit deeper and be a little bit more alert when it comes to the pregnant patients. But my second question is, do we offer the digital mammograms at our institution?
When you say digital mammograms, you mean tomosynthesis?
Yes, ma'am.
We do. We do. PMH offers 2D with 3D. Every patient that is going to get a mammogram will get 2D and 3D. And we also are one of the only institutions on the island that do the stereotactic biopsies for these patients that have suspicious microcalcifications, but no mass found on an ultrasound or another modality. So yes, we definitely have it, and we're open.
Awesome. Thank you.
Yes, thank you so much. Mammogram is open for business, so let us go ahead and get our patients referred so that we can detect any abnormality early and get the treatment started. I recognize the hand of Dr. Deval Rule. You can unmute.
Good morning, Dr. Minnis. Excellent presentation. So I'm asking this question as the clinician on the family island. So when these patients are referred to Nassau, well, most of them would go to a private institution to have some imaging done. If there's something suspicious, does the radiologist pick up the care from there? How is the patient routed? Because as we can see, time is very precious. And so how is the patient routed from the point of something suspicious being seen on any diagnostic test, or in particular a mammogram or ultrasound in this case? How are they routed from there?
You're muted, Dr. Minnis. We're not hearing you.
Sorry. Keep muting. So in radiology department at Princess Margaret Hospital, once the patient is referred to us for either imaging and or a biopsy, if the imaging findings are suspicious and we need to do further investigation, our secretaries and technicians in the department will follow up with that patient and ensure that they come back in to get that follow-up investigation and or biopsy. So generally, we would not allow the patient to go back to their referring physician for them to have to come back to us just, for them to tell them, now you need a biopsy. We would pick up the phone and call them for that. As far as the results, what we used to do, and it's not done as often now, is once the results would come in, we would try to get them an urgent appointment with either surgical oncology or the surgeons. Now, that process is it's a little bit nerve-wracking for the patients because you're calling them in on the same day, giving them the reports, and immediately taking them down to the surgical clinic. And so what I try to do is to tell them, please make sure you get a follow-up appointment in the surgical clinic, whoever referred you. And if you were from the family island, I try to get them a clinic appointment so that they can get the results in the clinic and move on. I try to, if I see suspicious features on a biopsy patient, to book them for their scan prior to leaving the department so that by the time they sit in with their referring physician to actually get that results, they would have already been staged and they're just receiving all of the information and they can move from there, as opposed to leaving, going to get their going to get the results, then having to come back for a staging CT scan. So I try to do it on the front end before they get to their referring physician. So that's usually the line that I try to take with the patients in radiology department. I hope that helped.
Okay, thank you for that. We have another raised hand. Dr. Thompson, you can go ahead and unmute.
Good morning, Dr. Minnis. It's a privilege to hear you again. My patient continues to sing your praises, and the love of God was surely exhibited during the time she had that encounter with you. And she's doing so well, getting ready to have surgery, a mastectomy sometime this month. I had an incident too where I sent a patient to one of the private institutions to get her mammogram. And because it was suspicious, they immediately scheduled her for biopsy. And so I said to her, she phoned to tell me, and I said to her, no, don't allow them to do it because you're going to be shared. You're going to have to pay X amount of money. So I immediately asked her to cancel the appointment, and then I set her up to go to oncology. And she has been actually doing well as well. So I know sometimes when they see it's suspicious, they just automatically book the patient for a biopsy. But then what happens when they enter the public sector, they have to redo the biopsy because they don't share the results with the public. Private don't share the results with the public. So therefore, the patient has to repeat that biopsy. So I say, if you send your patient off, ask the radiologist, the person who does it, to send the results to you, and then you can review it, and then you can guide your patient appropriately. And so that's the experience that I've been having. When I send patients off, I ask them they send the results to me, and then I channel the patients in the appropriate area that they need to go to. Thank you. And thanks again for your presentation. Good job.
Okay, thank you, Dr. Thompson. We have a question in the chat. Are bone scans available in Nassau? And if so, where is it available? Thank you for this very important presentation.
So bones, and I could correct me, the nuclear medicine scan for bone scan itself, I do not believe that is available on island. PET CT is definitely available. That can help you with evaluating bone metastasis. That makes sense.
And we have some comments. Excellent presentation, Dr. Minnis. Excellent presentation, Dr. Minnis. Do we have any other questions or comments for Dr. Minnis? Okay, I guess everyone else have understand fully what you have presented. Again, it was a very excellent case. I thoroughly enjoyed going through that case. And it's a very good reminder that we should all keep a high index of suspicion and have be very quick to refer to get our patients to the appropriate treatments. So we have another message that's coming in from your team. Excellent presentation, Dr. Minnis. Yes, we noticed your team was out in full effect to support you, and that's wonderful. Okay, so if there are no other questions or comments, we would like to once again thank Dr. Minnis for taking time out of her schedule to present this very, very important topic, particularly as we are recognizing October as Breast Cancer Awareness Month. So thank you, Dr. Minnis. Thank you, thank you, thank you. And I would like to remind all of you that we will continue with our regularly scheduled CME session the last Friday of this month. So look out for that notification. Oh, brilliant case study. Someone got in just under the buzzer. Brilliant case study. And I absolutely agree. So please stay safe out there on the roads today. Do everything that you need to do to stay safe. Oh, we have a reminder coming in. Please remember Research Day. Research Day is indeed coming up at the end of the month. I think, if I'm not mistaken, it starts October 23rd. So look out for all of those notifications that will be coming out regarding Research Day. Come out and hear all of the wonderful presentations will be done by our very own colleagues who would have completed their research for their DMs and other research work that is being done in the Bahamas. So please look out for that. It's always a wonderful time, very fun-filled educational sessions for Research Day. So Please enjoy the rest of your day, and I will see you the last Friday of this month. Have a great day.